Okay, welcome everybody to another ForceNet webinar. We appreciate your time and attendance. Today we have Dr. Yin with there from Mayo Clinic. Currently, Dr. Yin is associate professor in medical physics. She had her training and PhD training in bioengineering from the University of Illinois at Chicago. Her main focus of her research is on using magnetic resonance electrostography. Sorry about that with that elastography, MRE, to gain insight into mechanical properties of biological tissues, such as tissue adherence, stiffness, and viscosity, tissue viscosity. With that, she has several topics that I think this group will be particularly interested in with that. And we will have the audience type in your questions as we have in the past in the chat. You can just enter them in, and then toward the end of the talk, we'll open it up to have her respond to the questions in the chat. And without further ado, we'll turn it over to Dr. Yin.
Thank you very much for that warm introduction. And can you hear me right, first of all? Okay, great. Let me share my screen for now. And can you see my title slides? Okay, great. Again, thank you for that warm introduction, and thank you for having me here. And I'm really appreciate this opportunity to talk about our work related to the myofascial mobility and the myofascial pain using imaging. We used the MR elastography. So before getting straight into the myofascial mobility, I just like to briefly show you how and why I get there. So my background is in the imaging physics, and from the beginning of my research, I've always been fascinated by just finding ways to visualize how tissues actually move and interact, not just their shapes on MRI, but also their mechanical dynamics. And MR elastography has been the key tool that allows me to see those motions that in vivo. And much of my work has focused on the brain dynamics, including like brain tumors and the sports concussion. And I'm particularly interested in the slipping, sticky, and deformation that occur at the tissue interfaces. And on the left, you will see this brain tumor that's superimposed with the introduced MRE vibration, where we've amplified MRE emotional lot by like 800 times. So you can watch how the brain and tumor interact along their interface during that MRE vibration. And on the right, you can see this skull-brain decoupling motion, and just notice like how brain moves differently from the skull, and even different regions of the brain move differently from each other under the same vibration. So what's cool about this that I think is by looking at the mechanical interactions between the interface, for example here, between the brain and the tumor at their interface, we can quantify the degree of adhesion, the information that is crucial for the pre-surgical planning. I'm sure you can tell that a adherent tumor would require more effort and time to remove, and posing a higher risk of surgical injury compared to one that separates easily. And this is one of our collaborative studies where we recruited like 193 meningioma patients and then do the kind of a pre-operative imaging, including MRE. We find that MRE predict adhesion correlates strongly with the surgeon's intraoperative assessment. And adherent tumors also show trends of kind of a greater blood loss and longer resection time and just more severe surgical post-surgical injury, and confirming that these mechanical signatures can carry important clinical relevance. And with the skull-brain dynamics, and we're trying to understand just how repetitive subconcussive head impacts may disrupt the brain's natural mechanical isolation at the skull-brain interface. And on the left is a study from another research group that's showing kind of a meningeal injuries just right at the skull-brain interface after the mild traumatic brain injury or concussion. And our recent work echoes that findings, and we see that even at subconcussive levels, repeated head impacts lead to increased shear-driven stress along the brain surface. And that's important because the brain is particularly sensitive to the shear forces, which are thought to correlate with a diffuse axonal injury commonly seen in the sports-related concussion. So before this apparent injury occurs, we can already observe the mechanical signatures that may point to the increased vulnerability. And I know this audience isn't here for my brain studies, so I will leave those behind. I just want to use this opportunity to share that background, so to show how I came into this field of myofascial pain. And I'm still relatively new to this area and come to it from an imaging and biomechanics perspective. So please bear with me if I describe things a bit differently than you might do in your pain science or the immunotherapy or clinical work. So from a biomechanics standpoint, I'm really applying the same mechanical lens to the different problem, looking at how tissues move and interact at their interfaces, and trying to identify mechanical features at the myofascial interface level that may relate to what clinicians can feel through their palpation. So the condition that I've been particularly focused on started is the myofascial pain. And it's common, often chronic, and involves both muscle and fascia. I know this is very familiar to most of you, but again, it's being emphasized by many other studies, and also here that our full understanding of this is still quite limited. And prevalence estimates ranges anywhere between 30 to as high as 80% of population. And that wide range alone shows how difficult it is to pin down, because the diagnosis today is almost entirely based on relatively subjective clinical evaluations like palpation, trigger points, and patient self-reported symptoms. And without clear objective biomarkers, it becomes very challenging not only to confirm the diagnosis, but also to evaluate how well the different treatments are working and to compare therapies across studies. And one of the biggest challenges in caring for those type of patients from the imaging perspective is the disconnect between what clinicians and patients can feel and what imaging reports often show. Here's a typical patient you probably have seen before, a 20-year-old female coming to the clinic with chronic low back pain. And when we talk about chronic low back pain, we know nearly almost every anatomical structure, if they go wrong, they could contribute. But so after some kind of first-line evaluations, we ruled out some potential major pathologies and noticed obvious kind of lumbar perspinal tenderness or tension on palpation. So to the physician's hands, something is clearly wrong. But then she had the opportunity to get an MRI, and the report comes back normal. Nothing to explain what just detected. And this discrepancies are very frustrating, especially for the patient being told that nothing is there when they live with pain almost every day. And it makes us thinking, are we truly measuring the right things? So coming to this field of pain science, I learned a lot. I learned that pain is not just about tissue injury, but more like cumulative effects of many physical, emotional, and environmental stressors that can overflow a person's ability to cope. And this projection map makes it even more striking, and it's based on a map model of low back pain. And you can see just how many interconnected factors feed into that experience. Tissue damage and mechanical disruption, yes, but also central sensitization, stress, poor sleep, nutrition, mental health, work demands, social contacts, and you name it, almost everything. And when I see it like this, it's obvious that there's no single magic biomarker that can fully measure or predict pain. Well, I really much appreciate the concept that the issues are not in the tissues. Still, I think the imaging plays a valuable role in understanding at least part of the picture. Those can be objectively measured. The standard imaging like MRI, CT, ultrasound gives us an excellent window into the structural and sometimes pathological aspects like tissue injury, inflammation, degeneration, edema, or tears. And those are still critical pieces of the overall pain experience. But they don't capture the biomechanical parts, deficits that are the fascial mobility changes that are more functional related. And the hope is that the advanced imaging can help this further, not to replace the complexity of the pain with a single marker, but trying to make some of those invisible components visible and to help reduce barriers for patients where the standard imaging has come up empty. And that's my goal. So how should we approach this in the context of myofascial pain? We all know that muscle and fascia work together as a cohesive unit to support proper function. And in a healthy state, the myofascial layers kind of transmit load efficiently and glide smoothly against one another. And it's been demonstrated that this is primarily due to their natural elasticity and the lubrication from hyaluronic acid. And that lubrication is produced by fasciocytes in fine milling in those kind of loose connect tissues, the sliding layers between the myofascial units. And they respond very strongly to the shearing motions. One of the pain theories that when it's not being properly stimulated, such as overuse, misuse, or immobility, what happens is that the system starts to kind of break down. The hyaluronic acid tends to densify and become more viscous, more sticky, and less effective at transferring the motion. And this loss of lubrication changes mechanosensory feedbacks, disrupts the load transfer, increases stiffness, and over time, microinjury that accumulates, leading to the inflammation, fibrosis, and adhesions. And clinically, this could translate to what patients feel with that restrict motion and higher resistance. Well, when a patient comes into the clinic with suspected myofascial pain, the evaluation almost always begins with palpation. And once more kind of significant issues are ruled out, and the predominant treatment, one of the predominant treatment approaches are often some forms of force-based manipulation. And there are many techniques, but the shared purpose is really to reduce the tension and improve the range of motion. And whether it involves muscle palpation or the force-based treatments, the practitioner usually applies both compression and shear forces. And this means pushing down the tissue and sliding laterally, naturally with various levels of force or the different methods, just depending on whether it's for the diagnosis or for the treatment. What these techniques have in common is that they assess the stiffness of tissue by evaluating how much force is needed to deform the tissue, and also evaluate the tissue's ability to deform along that shearing plan. And this is exactly what MRI elastography can do. It functions like palpation, but with imaging, allowing us to see and measure how tissues respond to force. And with that in mind, let me just walk you through first how MRE works briefly. Elastography is often described as palpation by imaging, and there are many types of elastography like ultrasound elastography, optical coherence elastography, or MRI elastography. And for those less familiar with the concept of elastography, it is simple but powerful. So instead of using our hand to feel how our tissue deforms, we can generate mechanical waves, watch how they move through tissues through our imaging device, and measure how their properties changes or they reflect quantitatively. And it allows us to measure the tissue deep inside the body, and especially in areas where the physicians can't reach with their palpating hands, for example, like the brain tumors I just introduced before. And MRI elastography is done, such a technique that is done by MRI. And it was invented and commercialized here at Mayo Clinic by Dr. Richard Yin and colleagues. And its first kind of publication is back in 1995, and since then, it grows rapidly, moving from just research ideas into an imaging modality that now applied across every nearly major organ system. And today, the main clinical application of MRE is in the liver and to assess the liver fibrosis, where it has become the gold standard to replace liver biopsy and being recommended in many clinical guidelines. The liver MRI technique, only in the liver part, is FDA cleared since 2009, and it can be reimbursed with its own CPT code, and has already installed on more than 2,800 MRI systems across all major MRI vendors. So I'll use liver MRE as a quick example to show you how the technique works. The MRE starts with the external vibration source placed outside the scanner room, and this device kind of generates low amplitude vibrations on order of microns and deliver them into the body through a soft driver kind of placed over the liver in this case. And inside of the scanner, we use a special imaging sequence to capture the resulting shear waves. The imaging you see here in blue and red are wave fields. They show literally frame by frame how mechanical waves propagating through tissue. And with post-processing algorithms, these wave patterns are converted into the quantitative maps called elastogram, which provide measures of mechanical properties like stiffness, elasticity, or the viscosity. And here's just another brief example showing how we get the waves into the brain. The setups look similar. We still need this kind of outside kind of the vibration system to deliver the vibration. But with a different from liver MREs, we use what we call the pillow driver. It rests under the patient's head and introduce the gentle vibrations that travel through the skull into the brain. And just like the liver, MRI sequence picks up those tiny mechanical shear waves, and we're again talking about in the range of microns displacement, and convert them into elastogram that quantify the brain's mechanical properties to study in most of the field of brain MREs how kind of mechanically brain changes with aging, the neuroinflammation, or the neurodegeneration. When we translate this same MRE principles into the muscle, the basic concept is still the same. Just apply gentle vibrations, capture shear waves with MRI, and turn them into maps of mechanical properties. But in muscle, the challenge is that one size does not fit all. Unlike the liver and brain, where the anatomy is relatively fixed, the muscle groups we want to study vary widely in size, depth, and orientations, and that means the driver setup has to be tailored for each region. And over the years, we've developed a toolbox of passive drivers that designed specifically for the different muscle groups. For example, for the lower leg, we have a compact setup that wraps around the calf combined with an adjustable foot plate and also with different cell loadings, and to deliver vibrance with different positions and loading conditions. And in the thigh, we have this tube driver just wrap around the leg simply to transmit shear waves into the quadriceps and hamstrings. And in the lower back, which is going to be my main focal state, we have this belt-style driver that's strapped around the lumbar region and designed to couple the vibrations into the kind of the low back muscles. And each of this is just engineered to deliver vibrations in just the right way for its target anatomy. All those kind of stuff.
Dr. Yin, your sound, your sound maybe kind of go in and out with that.
How about right now? Is that good? Awesome. Thank you very much. Thank you for reminding me. There's a bit problem with my audio. So when we talk about elastography, any forms of elastography, the first thing that you think about is always measure the muscle stiffness. And here's an example with the biceps, which is a very kind of early study from our group, that on the left, the muscle is at rest with no load, and next to it is the same muscle under a 4-kilogram load. As the load increases, the muscle becomes stiffer, as you can see this directly in the wave imagings. The wavelength gets longer, which is the physical signature of the higher stiffness. And on the right, you can see this almost linear correlations between the shear modulus and the load. And this simple observation by that time generated a lot of excitement in the biomechanics community because it demonstrated that we can move beyond just the static imaging of muscle anatomy, but start to capture the functional mechanics. And here's just another example, this time from a research team studying the lower back, and they measure stiffness in the rectus spinae and multifidus muscles in the lumbar regions, both at the rest and during the contraction. And as expected, the muscle just becomes stiffer when the muscles are contracted. And those are the classical applications of MRE, measuring muscle stiffness under different functional conditions. But from my perspective, I think stiffness alone doesn't fully capture what we're most interested in. And what really kind of interesting matters in the myofascial system isn't just stiffness, it's really how will the different layers move relative to one another, how mobile and how restricted interfaces are. But this is not easy because we are talking about this thin and delicate structure, one that lies beyond the resolution of MRI. So if we require hypothesis that healthy fascial layers provide a smooth gliding surface between muscles, but when the system is impaired, these layers can stick together, restricting movement. How do we measure it? Clinicians and you guys already try to feel this with your hands, and we just measure it with imaging. And with MRE, the vibrations apply to the tissues, which are then passively moved by this, tissues are passively moved by this input. And in regions where the tissue layers have a slip interface, the two tissue layers kind of move relatively independent to each other, and a large shear strain occurs. But in areas where the layers are stuck and cannot move freely, the shear strain is much smaller, and that difference gives us a direct window and contrast into the interface mobility. And this is measured using a method we call slip interface imaging, or SII. It's still based on the same MRE setup, but with different processing. We first developed SII, as I briefly talked about it, beginning to tackle a very practical surgical questions when planning to remove a brain tumor, such as meningiomas, vestibular schwannomas, or pituitinomas. We would like to predict how tightly that tumor adheres to the brain. And surgeons often face this uncertainty. Sometimes the tumor just peels away easily, and other times it's inseparable and needs sharp dissection. And that difference has huge implications for the surgical risk. Those are two examples of meningiomas. On the left, you see these bright shear lines at the boundary of the tumor, and that's a clear slip interface, meaning the tumor and brain tissues have a large relative motion with a large shear strain, so it can likely be separated from the brain tissue fairly easily during the surgery. But tumor on the right shows no such high intensity contour at its boundary, so this tumor is likely to be firmly adherent to the brain, and surgeons could face a much more complicated and delicate resection. And we can also generate our 3D adhesion surface maps, use different colors to indicate the different kind of adherent levels to further help with the surgical planning. When kind of translate this concept into the lower back, it's not a straightforward translation. We did a lot of efforts trying to design the best driver position, and to optimize our sequence and post-processing. And finally, we have our built our kind of a specialized build driver that wraps snugly around the lumbar region, so right at the lower end of the paraspinal muscles. And also to ensure the accuracy, we place those small fiducial markers on the driver, which helps us to consistently align the belt with the anatomical landmarks for the different patients. So once that driver is in place and we're happy with its position, it just delivers vibrations into the lumbar tissues. You can think of it almost like plunking a string, and the vibrations are introduced at the lower end, and they travel upwards along the muscle fibers, generating those wave motions through the whole low back muscles. And this type of proper gating wave patterns are essential for us because they gave us the relative motion between the different fascial layers that we need to evaluate their mobilities. And importantly, the protocol is fast and practical, and each scan takes less than 4 minutes, and making it feasible to incorporate into a routine MRI exam if needed without adding too much heavy burdens on patients for the workflow. Like with the advanced post-processing, and the results we're getting are very encouraging. Here you are looking at the cross-sectional slice of the lower back from healthy volunteers. On the left is a standard MRI. It gives you this familiar picture of the low back muscles, the erector spinae, motive disc, and the quadratus lumborum muscles. And on the right is the corresponding shear strain maps. Just notice how those high intensity contours outline muscle boundaries between every kind of myofascial layer. They're showing us where the shear strain is concentrated, which corresponding to where the one fascial layer is sliding against another during MRE vibration. And we're particularly interested in the interface between the erector spinae and the motive disc, as well as between the erector spinae and the QL muscles. And those interfaces muscles have been reported to highly relate to the pain. And those sharp boundaries confirm us we can, in fact, visualize the relative motion at those critical interfaces. And another good thing about MRE is that it's a full 3D acquisition. That means we can evaluate it in the multiple views, like from the axial, coronal, and sagittal views. And the key feature again are those looking at those bright high intensity lines that marking the myofascial boundaries. A bright signal means high shear strength, large relative motion, and good mobility at the interface. If we don't see that signal disappears or fades. It may suggest the tissue is more adherent and restricted. And to move images from numbers, we develop a pipeline to quantify the interface mobility, and that workflow involves kind of the several technical steps like the muscle segmentation, strength pattern analysis. And I won't go into detail here, but highlight the two key outcomes. The first is the surface map of the interface. Here shows an example between the erector spinae and multifidus, and where we use the blue to indicate the unrestricted regions and the red with restricted regions. And from that map, we can also calculate a single summary value we call it mobility index. And you can think of it like a score of how freely two layers can glide against one another. A higher index means greater mobility, and the lower index just restriction or the adhesion. And whenever we develop a new kind of quantitative method, one of the first questions is always, can we trust those numbers to be consistent at least? So to test this, we scanned 17 healthy volunteers 3 times, twice on the same day and once again 2 weeks later. And we then calculated the within subject coefficient variations, or WCV, to assess both the within day and between day repeatability. And for your reference, the WCV under 10% is generally considered excellent for the quantitative imaging. And here our results were even better. Across multiple imaging muscle interfaces, WCV was consistently below 5%. And on the right, you can see this flat outline plots where the red lines indicating the bias, and we see very minimum bias, almost towards zero across repeated measures. And within this current validation, at least this data set, we are confident that our technique has a high repeatability, which is essential if we really want to use it clinically. So what do we actually see this in patients? And here's the same patient that I showed at the beginning, and now side by side with the age, sex, and BMI matched healthy volunteers with no back pain history. And on standard MRI, there's nothing kind of significant to explain her pain, and both skin looks relatively normal. But with MRI, and SII, we began to visualize something different. So when we look at erector spinae and multifidus interface specifically, and in healthy volunteers, you can easily track down this distinct bright kind of interface along the muscle boundary. But in the patient, it shows that this interface disappears somehow as we're tracing down from L3 to L4. And this is again showed in our 3D adhesion maps on the right. The healthy control just shows mostly blue with the unrestricted interface, while the patient shows more yellow to red areas, indicating kind of more restrictions. And this is the imaging evidence of a reduced slope interface, consistent with the hypothesis of the myofascial adhesion. And this also aligns with, I'd like to bring back Dr. Langerman's kind of this early ultrasound studies of the thoracolumbar fascia. And we probably all familiar with this, and where the participant are lay kind of prone with their legs were passively flexed, and ultrasound was used to visualize the fascial layer motion for the thoracolumbar fascia. And what they found is that in healthy individuals, the fascial layer glides smoothly and with clear sliding between layers. But in patients with chronic low back pain, and this sliding was reduced, showing much less differential motion between the adjacent layers. And they also reported about 20% reduction in the shear strain in the patient group. And this just provides another independent evidence that restrict fascial mobility is linked to the pain development. But we all acknowledge that ultrasound has its own limitations. It can only access superficial regions, also has a large operator and angle-dependent variabilities, always has some challenges trying to generalize or standardize across patients, which is not quite a problem for MRE based on our current data set. So back into our own study. And this project begins in 2022, where the adhere biomarker imaging initiative started. So so far we scanned 20 patients with chronic low back pain that associated with myofascial pain. And those patients that they must have no treatment within the kind of the previous 3 months. And also this patients there in our patient population, we somehow has some overlapping fibromyalgia. And we compare them with 20 age, sex, and BMI matched healthy controls. The age difference are about kind of 3 years and within kind of 2 BMI units for the variation. We also stratify patients by their PEG scores. And the PEG scores for less were classified as having mild pain, and for those above 4 was classified as moderate to severe pain. And when we look at mobility index at the interface, particularly the ESM interface at all 4 levels, the mild pain group showed a wide spread of values overlapping substantially with the healthy controls and no significant difference. But patients with moderate to severe pain demonstrated a significant reduction in mobility index. In other words, like reduced sleep interface mobility at this lumbar level. And this finding suggests that impaired myofascial plane motion may be associated with the kind of a greater pain burden. And we also, because we have this unique data set, we also want to explore if the fibromyalgia plays any role, that central sensitization plays any role on top of this. Maybe some patterns.
Dr. Yin, your sound again. We apologize. It's just a catch in our system.
Can you hear me now?
Yes, yeah, you're good.
Okay, my apologies again. It's really my system issue. So I think I was just saying that we see some of these interesting patterns in the fibromyalgia patients, but we just need more cohorts, and we're actually working on that to fully understanding this. So we also look at whether our measured mobility index correlates with the pain score. And what we see here is a clear negative trend, and patients with lower fascial plane mobility tends to report higher pain levels. And the correlation is not perfectly linear, but in pain research, and I think that's exactly what we expected. It is such a complicated thing, and we don't expect a single measures will ever fully explain it. What really interesting that we may start to see a signal could help us stratify patients. Like imagine being able to identify in advance which patients are most likely to benefit from those fascial-based interventions. For example, look at those patients with PEG scores around 9. Some still show relatively high mobility, while others fall into the low mobility range. And this could open the possibility of tailoring treatments based on their baseline mobility. And patients with true mobility deficits may benefit the most from the manual therapies that restore the fascial plane sliding. But the patients whose fascial mobility is already within the normal range may not respond in the same way. And for them, the pain may be more driven by the other mechanisms, such as central mechanization or the neuroimmune factors, and just may need a different therapeutic approach. And the key is really to identify them beforehand. And also, this is just simple correlation. We don't know whether this loss of mobility is a primary driven of the pain or a secondary adaptation to the pain. And there's no evidence from our data can answer that question yet. Up to this point, I show you that what we can already measure in the patients, and we've started to see the evidence that fascial plane mobility differs between those with and without myofascial pain. And the next step, and this is where we're headed right now, is not only to detect the differences, but guide treatment and to connect directly with the clinical practice. We're not fully there yet, but this is exactly the focus of the next phase of our study and integrating the clinical interventions and tracking the treatment response. So happening right now, and we're running a randomized clinical trial to study the treatment effects of one type of force-based manipulation therapies called TWINA. And for those less familiar, the tuina is one of the oldest form of manual therapy with a history of 1,000 years in the traditional alternative medicine. And the name itself comes from two core actions. Tui means push, and na means to lift and grasp. And beyond those, there are a variety of other type of maneuvers like striking, pressing, rolling, tapping, and all aim to relieve muscle tension and to reduce adhesions between the myofascial layers. Mayo Clinic has already conducted a multi-center randomized clinical trial on tuina for a non-specific chronic low back pain led by Dr. Brand Bauer. That study demonstrated the valuable of the clinical benefits, but what it didn't capture was the biomechanical mechanism. We still didn't know how tuina was working at the tissue level. Now with this funding from the NIH initiative, we are launching a multi-year trial to understand this. So in this trial, the patients receive a structured 3-week course of tuina treatment, and we are collecting imaging at 3 key time points: baseline and immediately after very first treatment to understand that short-term effect, and again at the end of week 3 to evaluate the long-term effect or relatively long-term effect. And this design allows us to ask 2 major questions. First, does tuina physically restore the normal fascial sliding and gliding at the tissue level? Clinicians have long hypothesized about this, but until now, as far as I understand, we still don't have the tools to measure it directly at the tissue level. And second is, can baseline mobility help us predict which patients are likely to respond versus those who may not? And if we can answer that, it would move us closer to a personalized approach for force-based manipulation, just matching the right patients with the treatments that most likely benefit them and avoid that one-size-fits-all model. And that's where this research is heading, and we're pretty excited about that. And I also want to emphasize that what we're developing here is not limited to tuina. I think the core idea is much broader, and any force-based manipulation that truly release kind of myofascial restrictions, whether it's tuina, physical therapy, myofascial release, or the other any type of osteopathic manipulations, should leave a measurable fingerprint in the tissue. And where our imaging approach has this potential to serve across different interventions and to measure and compare techniques in a more objectively way. So far, I focused on work in patients with chronic low back pain. That's where the clinical need is most urgent right now. But in parallel, we've also been developing and testing this technique in other anatomical regions, not yet in the patients, but in the feasibility studies. And these are more like exploratory and designed to see just how broadly the slope interface imaging can be applied across the body. I'll just show you 2 kind of quick examples. One example is the functional myofascial interface of the flexor digitorum profundus FDP muscles. And this muscle is particularly fascinating to me because it controls individual finger movements through the finger-specific tendons. But anatomically, it doesn't have separated compartments for each finger. So the way the mobility and forces are transmitted within this muscle relies heavily on its internal functional interfaces, functional boundaries that cannot be seen on the conventional anatomy alone. So on MRI, you can recognize the general regions of FDP, but you don't see the clear divisions between the parts serving each finger. And that's where things get interesting. So if we can apply the vibrations through one finger at a time, let's say starting from index finger, those vibrations travel along the tendon and into the muscle. And what we observe is that a specific region inside the FDP lights up and outlined by this high-intensity contour. And now if we switch to the middle finger, a different region is activated. And the same happens with the ring and little fingers, and each one just highlights their distinct zone inside of the same muscle. So this means that we're not just capturing anatomical boundaries, but really those kind of functional boundaries that are more relevant in that conventional imaging that simply cannot tell. And my kind of a very final example, quick example, is in the thigh and focusing on the deep intermuscular fascia that separates those major muscle compartments of the quadriceps. So to investigate this, we decided a custom tube driver that wraps around that control operations.
One more time, Dr. Ying, on your sound.
How about now?
Good.
Sorry again, one more time. And we developed this tube driver to kind of generate waves that tune into the kind of the thigh regions. And if you look at the shear strain map, and you can see those kind of high intensity contours, those interface, slip interface between the muscles. But notice the regions between the VI and VI separations. The separations is not here. And this is not expected because we are imaging healthy volunteers and no adhesion should be expected. What we later found was that body posture makes a big difference. And with the legs straight and those interfaces become much more clearly defined and compared to when the knees bent. And this tells us two things. First, our method is quite sensitive to those dynamics in the intermuscular myofascial interface changes under different muscle conditions. And second, just like in palpation, the body position is important. Same here. We find that to help with the interface visualization, all measures should be done when the muscles are in a more relaxed and neutral state. And moving forward, there's some major directions for the future development of SI and MRIE. And I'll just briefly mention that first, we want to extend this work into the other anatomical regions, like the upper trapezius, which is the heavy burden right now, and also the lower leg, and to explore the broader applications. And second is we're working on mapping that slip direction, not just the magnitude of motion itself. So instead of asking only, is there mobility or not, we can now begin to ask which way the tissues are preferred to slide. And this additional dimension may help us better understand the dynamics of structural interfaces. And also at the same time, we are also extending into the classical MRE property mappings like measuring stiffness and viscosity. And actually, the lab here has done some preliminary studies from about a decade ago, looking at the top band stiffness in the upper trapezius in the myofascial pain. And those studies did see an increased stiffness in general, but the regions of the exact location where this increased stiffness did not always align perfectly with the clinician's palpation kind of assessment. So our hope is that with the technical advancement over the years, and we can revisit and solve that puzzle. So this is really my last slide is ultimately our goal is just trying to develop imaging method that can bridge this gap between the clinical evaluation palpation and advanced imaging, and trying to develop something that is helpful for patients and also can be used in a quantifiable, shareable, and reproducible way. And my last acknowledgement, fundings for sure, and Dr. Richard Eman and his kind of MRE lab for the whole kind of basic support, my own team member here, and Dr. Brent Bauer and his colleagues for the clinical collaboration. And I'll stop here and thank you very much for your time and attention, and I apologize for my multiple kind of pause due to my audio problem. And it's very excited to hear your thoughts or the questions, or can chat offline if that works better for you.
Okay, thank you very much. I'll do my best to cover the comments and get the majority of them. With that, you had mentioned different types of FBM with there. Has there been any of this work done with dry needling or acupuncture before and after? We were just curious with there on that particular type of FBM.
Yes, so that's a very kind of intriguing questions. I think we to my knowledge, I think we are the one who is doing this only at Mayo Clinic right now. I do not think this technique, if I understand correctly, they're asking if this apply to other kind of interventions. Not yet. I believe this is first one we are currently testing, but we like to test more if there's opportunities.
Okay, excellent. Another one asks, how do we know if the myofascial imaging findings are actually related to the nociceptive pain generators? Or basically, are we finding an abnormal finding, but yet has nothing to do with the clinical presentation of pain?
So my disclaimer, I'm not a pain expert. I'll try my best to understand from imaging perspective. And I think what we are detecting here is absolutely, it's just an imaging method to see if there's a problem, what it will behave mechanically. I do not think we're at that point to actually can directly link to the pain generator or the mechanism point. So that's it would be great if we can directly link to that, but I don't think we have the capability to do so.
Okay, excellent. With there, as far as, are you aware of any local biochemical correlates with altered strain patterns of muscle groups? So any biochemical correlates?
Um, well, first of all, I may not fully understand the question. What is the local? What does that related to? If
I
the
think any
yeah.
biomarkers, any other biomarkers that would correlate with
Oh,
altered strain patterns.
oh, biomarkers, other imaging biomarkers you were saying.
Yeah.
Okay, so there's no, I think there's ultrasound group. Definitely they are looking at fascial mobility in a lot. And also if you look at imaging biomarkers related to this potential myofascial, the T1 role mapping might be someone that who the researchers have been previously reported because that is directly linked to, based on MRI theory, directly linked to the hyaluronic acid concentration.
Okay, all right, okay, with there, and that's what I think the hyaluronic concentration or maybe lactic acid buildup, something physiological. I think that the question was kind of getting at: is there any other? Are they correlating between physiological changes, biochemical markers?
I see.
With that, okay, with that. As far as two questions were kind of evolving around patients that have hypermobility, whether the cervical spine or the joints. Have you actually specifically sought out patients that have some type of hypermobility condition with that and have done these type of procedures in imaging?
Yes, so that's a great question. And we are there's a lot of things kind of came down with our technique. I think currently, because we are kind of NIH funded grants, we follow particularly focus on the myofascial pain currently for our patient group. And for the patient that we're recruiting, a very strict BMI has to less than 30 and no treatments and myofascial pain related. And because we're recruiting those patients from the Mayo Clinic has a fibromyalgia clinic, which is very dedicated. So we started recruit a lot from them. So it has a chance to have kind of comorbidity there. So for the other kind of this is the hyper kind of motion restriction related, we haven't really do anything yet. It's just, but that's all ongoing that we're hoping to explore further.
Okay. And have you all got to the point of investigating relationships between the mobility index and the duration of symptoms? So if you have something for 10 years versus something for a year or 2 years, do you see a relationship there?
That's a great question. We did actually using our current data set to see the correlation between that and with the pain duration. We do not see a correlation there. And we also correlate that with number of trigger points and another kind of something related to that number of location trigger points. It doesn't correlate either. I think it's only related to our patient population. Probably just too limited with 20 patients so far.
Okay, and just to clarify again on the trigger points, one of the next question is dealing with trigger points as far as active versus latent trigger points, but there's been no association or correlation between identifying changes in the mobility and whether trigger points active, latent, are present.
So for us, we are approaching things. We just intentionally looking into trigger points and tender points, and we didn't specifically analyzing yet active and latent trigger points and correlation. But I believe, if I'm going to recall the kind of the clinical notes from our clinical collaborators, they are talking about active trigger points. I'm not quite confident about latent trigger points for now.
Okay, all right, all right. With that. Here's a kind of, I'll try to summarize a little longer question with that. I can imagine that this MRI would note intrinsic stiffness in the paraspinal muscles when people have lower extremity complaints. So basically, if they have a lower extremity complaint, have you kind of looked up into the trunk muscles and see if their stiffness changes are systemic or just in the area localized to the lower limb or to the trunk? Or do you see a association or relationship between lower and trunk anatomy?
Yes, that's a very intriguing question as well. And we currently for our patients, we just imaging their lower back. We didn't really beyond that range, but we did do the analysis starting in the kind of muscle stiffness kind of measurement for the patient and healthy volunteers. And again, maybe the like a number of patients is that we don't see a significant difference in the muscle stiffness itself for the MRE.
Okay. And have you used this technology far as to image the sacroiliac joint movement? And there's a limited range of motion in the sacroiliac joint, but have you looked at that the pelvis or any of the sacroiliac joint motion at all?
That's a great question. That's almost kind of the clinicians that are working with me. They kind of ask me, can you look at that? Can you look at the ankle? Kind of there's ankle problem with that adhesion problem. And I think when our technique theoretically, yes, we can. Anywhere there's two interfaces that has the abnormal relevant motions, we can do that. But technically and practical, when we look at not at the muscles for those kind of fascial, their insertion directly at tendon near the tendon, or the muscle volume is very low and small and very thin. It it is a little bit challenging for MRE to reliably do that measurements. So my short answer is we haven't reached that point yet. But our goal is to do that because there's a lot of clinical kind of high priority that asking, can we do that?
Okay, all right, excellent. We have another question on the spatial, while the imaging was very nice, it's showing a remarkable level of spatial segregation of muscle bundles involved in movement with that. But have you done pre and post like spinal manipulation? I know you looked at the massage, a form of massage, but has there been any studies done pre and post spinal manipulation?
So for imaging study, it's currently ongoing, and we are kind of a single blinded trial. So we're actively working on that, but we don't have any results. Can't analyze it yet. That's again, I think it's the very first study that I know that using the imaging, at least MRE, to do this. So please stay tuned, and I sure will share that once we get more information.
Okay. And has there been any type of pre-post with needling or some kind of intervention? Didn't have to be needling, I guess, but comparing with ultrasound to look
Oh,
at properties, the two types of technology, comparing ultrasound findings versus MRE findings.
there's not MRE findings is relatively new. I think ultrasound, yes, they probably done similar research to that area. There's no head-to-head comparison between the ultrasound and MRE yet. And also, I think ultrasound and MRE, they have their own pros and cons. They do things differently. Ultrasound motion, they're literally kind of, you can see that. It's in a centimeter range. But MRE, we're introducing vibration in the micrometer range, which means anything very, very small, subtle changes, we can see that. Um, yeah, I think we don't have comparison yet.
Okay, with there, another question that came to my mind is with that when you apply the vibration with there, are you directing are you intentionally directing the vibration in a certain plane with there? Are you just making perpendicular? Are you applying it to trying to match the muscle plane or the tissue plane? And does that change based upon tissue?
Yeah, that's a very good question. Actually, that's really the main technical points when we really want to do this. And for the brain tumors, for example, I just vibrate my head and the vibrations going in all directions. It's just the brain and the tumor, they're just separately moving. But for the muscles, because they have orientations, they have insertions, they're just different. I'm also doing the trapezius. I'm working on some now. They're rotating kind of thin layers. It's very complicated. So what I find that we have to specify our driver. For example, in our protocol in the clinical practice, we have a very dedicated protocol to saying how you need to align your driver position relative to an animal structure. And currently, I tried like 10 ways of doing the vibration for the lower back. I find the best way to actually introduce the relative motion for me to see that is literally from lower end of the paraspinal muscles. So vibrating from the bony end, and then the muscles kind of waves kind of traveling along the muscle fibers, and they move relatively depending on their different structure. And for the shoulder as well, I would, it's more efficient is putting the drivers in the scapulate, this kind of bony structures, and let those insertions kind of spread the vibrations to the different muscles. That's my experience, that it matters a lot.
Okay, excellent, excellent. On there, and have you noticed any differentiation due to the hydration of the muscle, with how much hydration there is? Or
That's a great question. We did not. That actually reminds me another limitation of our study is when we do a repeatability study, or kind of we didn't really restrict to the it has to be more studied in the morning or in the afternoon because we know kind of fascial differently. That's also a thing that I didn't when I first designed, I have to admit I didn't really take that into consideration. But we do later on kind of thinking whether that is a problem or not. We will I think that kind of relate to the hydration. Is that kind of a temporary change or permanent pathological changes? Is that affecting the final results or the imaging representation? And we are actually working on that to understand if there's a change or not.
Okay, excellent. With there, and as far as the stimulus vibration amplitude and frequency, has that been optimized or standardized? And then how does the BMI affect the more soft tissue or fat tissue that a person has with the same frequency or amplitude of vibration? How does that affect? I know you match the patients, with their according to BMI, but how does that affect do you change the vibration frequency or amplitude based upon BMI, or you just has it been optimized?
That's a great question. And we for the current evaluation, we have a BMI cutoff and 30. The reason I cut that off is because when patient has a large BMI, even though I increase vibration, sometimes I just don't get enough energy sent into the muscle. So when I don't see an interface, it will be hard for me to say, okay, it's because just the high BMI, the wave just not getting into the muscle, or it's because there's a loss of a myofascial interface. To avoid that problem, I kind of set the cutoff at 30. But below 30, all my patients, all the repeatability study, they use the fixed vibration amplitude because we tested, we find a kind of a sweet point that no matter it's high beat, I'm a small, tiny person. And whenever I tried it on those kind of a little bit heavier patients, I always try it on myself to make sure that works for both of us. And for the frequency, we tried 30 hertz, 60 hertz, and 90 hertz, and a series of frequencies. And we found that the lower frequency actually works better. 30 works better than 90.
Okay, excellent. Okay, well, I got to most of the questions. We will end. We're at 2 o'clock now with there, so we appreciate excellent presentation, a very interesting with there, and generated lots of interest. And we look forward to following your work in more detail as the years pass on, because I do think this has great potential for the field of force-based manipulation in all forms and fashions. So we'd like to thank you for your time with that, and for the audience for their participation and questions. I look forward to seeing you all at our next webinar. Thank you very much.
Thank you very much again, and I apologize for my audio issues again.
That's okay. We appreciate it. Thank you.
Thank you.
And you can hang around just for a few minutes.